Hello, you are most welcome, ladies and gentlemen, to your power behind the voice on Tuesday Night Anatomy with Daniel Okwan. We are still in the era of anatomy of clinical importance. And my friends, today we look at that of the ulnar nerve. Now, the most important thing which I want you to understand is that today we are going to talk about the various injuries, whether it's a higher level injury or a lower level injury. Okay, we want to appreciate that. And my friends, we want to look at the clinical manifestation of such injuries and which clinical tests that we have to perform, okay, to of course diagnose such injuries. And so, without wasting my time, let's set the ball rolling. Now, first things first, as far as the origin of the ulnar nerve is concerned, my friends, it is not coming from the entire brachial plexus. But my friends, by way of root value, the ulnar nerve, yes, will have C7, C8, and of course T1 root value. That's one thing I want you to understand. Now, again, unlike in the case of, the radial nerve, which there was some supply in, of course, the axilla, in the arm, in the forearm, what have you, my friends, as far as the ulnar nerve is concerned, okay, just like the median nerve we discussed just last week, you realize that as far as cutaneous and musculature innervations are concerned, the ulnar nerve has no role to play as far as the axilla, the armpit is concerned, of course, and of course the arm is concerned. So it will not give any motor supply, neither cutaneous innervation to these areas. But my friends, as far as the musculature innervation, okay, is concerned, it will commence in the level of what we call the forearm. So it tells me that it will occur below the elbow joint. But importantly, one important point I want to put across over here is that as far as bony prominences are concerned, the ulnar nerve will run posterior to, of course, the medial epicondyle. It will run behind the medial epicondyle. Now, as far as your arm is concerned, at the level of the elbow, we appreciate this medial epicondyle, a very palpable, this subcutaneous, bony prominence that we find over here. Okay, this is the medial epicondyle. If you want to relate it, it's in line with where the pinky is, the little finger is. Okay, so this is the medial epicondyle. And so it runs behind it. That is why if it gets, sometimes if this area of the medial epicondyle, this region, okay, you tap it against a hard object, you get that, funny feeling sensation, okay, where it's not pleasant at all anyway. Okay, so that is the medial epicondyle. It runs behind it. That's the first thing I want you to understand. And so, for instance, if there's an injury to this medial epicondyle, then of course this ulnar nerve, yes, could be injured. Okay, of course, also if there's this kind of medial epicondylitis, okay, there could be that kind of inflammation to this bony area, and of course it may also affect this ulnar nerve we are talking about. Great. Now, importantly, as far as the level where it's going to give motor supply, I said is the level of the forearm. The musculature, first muscle that is going to give motor supply, it actually runs between the two hairs of that muscle. And my friend, that muscle is flexor carpi ulnaris. That muscle is called flexor carpi ulnaris. Okay, so the first muscle which I want you to appreciate as far as musculature innervation, motor supply, okay, to various muscles are concerned, as far as the ulnar nerve is concerned, okay, is of course flexor carpi ulnaris. It's having two hairs, so it runs between two hairs, and of course it supplies these muscle fibers also. That's the first one. Okay, and then of course it will run in the cubital tunnel, okay, and then go downwards. But my friends, as far as the forearm is concerned, it is not only flexor carpi ulnaris that this musculature, this muscle will supply, this nerve will supply, but my friends, also the medial one half of flexor digitorum profundus, medial one half of flexor digitorum profundus also be supplied also in the forearm. Last week we said that the lateral one half of the flexor digitorum profundus will be supplied, but of course the median nerve. That's what we discussed the last time. Okay, but this time around the medial one half, okay, of what we call the flexor digitorum profundus will be supplied, but of course this ulnar nerve we are talking about. Remember that I told you that flexor digitorum profundus will be working at the level of the distal interphalangeal joint. Distal interphalangeal joint. So what? Because it's the medial one half, they will be working on distal interphalangeal joint of what we call the pinky little finger this way. without upon contraction, flex, okay, will cause flexion, as you can see over here, as well as that of the distal, interphalangeal joint of what we call the ring finger. Okay, this way. That's what we'll be seeing. So that of the lateral aspect will be taken care of by what we call the will be supplied by actually the median nerve we discussed the last time. So that's first that I want you to understand. Now, so it means that as far as motor supply, okay, of the ulnar nerve in the forearm is 1.5 muscle only. And what are these 1.5 muscles I'm talking about? The first one is flexor carpi ulnaris, and then the half is of course the flexor digitorum profundus, medial half. Okay, that's what we're talking about. Now, beyond that, what we see is that it will run, okay, at the level of the wrist joint. It will run at the level of something we call the Guyon's canal, okay, and then of course eventually it will go into the level of the palm. Now, when it gets into the palm, we are saying that beyond the level of the Guyon's canal, it divides into two. That's what we know. It divides into a smaller, superficial branch and a larger, deep branch. The smaller superficial branch, one thing we know about the ulnar nerve is that it gives, cutaneous supply to something we call the medial 1.5. Yes, medial 1.5 aspects. Okay, so this way of the palmar aspect together with the dorsal aspect of what we call the little finger and that of what we call the ring finger, medial. So it's going to give cutaneous supply all the way this way together with this area, medial 1.5 of it. Okay, so that's all. That's the supply of what we call the ulnar nerve, cutaneous supply. That's by the way of the superficial branch of the ulnar nerve after crossing the Guyon's canal. Now, the point over here is that is it that the superficial branch only gives cutaneous sensation to these areas of the skin? Okay, is that the case? My friends, it also does one more thing. Now, remember that last week I told you that as far as the muscles that produce this thinner eminence is concerned, yes, I mentioned what do you call it? Abductor pollicis, brevis. I talked about flexor pollicis brevis. I talked about opponens pollicis. Okay, I told you about these things. But my friend, I told you that there's one other muscle where it's subcutaneous. It doesn't really contribute much to this thinner eminence. That muscle, I told you about it, that is the palmaris brevis. Palmaris brevis, okay, is supplied also by the superficial branch of this ulnar nerve after giving the cutaneous sensation to the medial 1.5 aspects of the palmar and of course the dorsal aspects of the hand and the gates. Okay, that's what we discussed. Now, my friends, importantly, how about the deep branch? Now, there is the deep branch, okay, which gives, of course, a branch, okay, to supply the muscles that produce this eminence. Now, there's some kind of muscle that produce. Now, I said there's the thenar area, and this area is called the hypothenar area. Hypothenar. Now, at the level of the hypothenar, this eminence, which are called the hypothenar eminence, okay, the musculature, which are making this one up, will be supplied exclusively but for the deep branch of the ulnar nerve. And what are these muscles I'm talking about? Yes, we'll talk about abductor digiti minimi. Yes, this is the little finger, pinky, so digiti minimi. So we talked about abductor digiti minimi. Then of course we also talk about flexor digiti minimi. Then we also talk about openness digiti minimi. All these three muscles will be supplied, but of course a branch coming from the deep branch of course this ulnar nerve. So that's one important thing I want you to know. Now, number two is that we will have another muscle. Now, that muscle, or those group of muscles, we call them interosseous muscles, interosseae. Now, there are two kinds of interosseae. Now, one of them we call them palmar interosseae. Yeah, palmar interosseae, they are unipinnate. Usually they are three. Yeah, they could also be four. I'll explain it. And then we also have what we call the dorsal interosseae. Dorsal interosseae, they are four in number. They are bipinnate muscles. Now, one thing we know about, palmar interosseae is that as far as, you talk about pad, palmar interosseae, pad, and the AD is for adduction. So for me to adduct my fingers, bringing all the other digits closer to this middle finger, that is the work of what we call the palmar interosseae. Okay, pad. Then we also have dorsal interosseae, the bipinnate ones. Now, if you want to take the other digits away from this one, is by the concavity of the muscles in the hand. One of those intrinsic muscles in the hand, we call them, the dorsal interosseae. Okay, and the dorsal interosseae, then the one for you to remember the function that they will perform is of course abduct the various digits from of course this middle finger. of the hand. Yes, that's one thing we should understand. Now, so we will appreciate the clinical test that we perform to check the integrity of these muscles, that whether they are getting adequate supply from this deep branch of what we call the ulnar nerve. Now, is that all? No? There's one more muscle, or there are two muscles actually. Those muscles, one thing that we have to understand is that last week we came across, two of them. Yes, the unipinnate ones, L1, L2. I'm talking about the lumbricals, the worm-like muscles. Okay, so this one too, the medial, two lumbricals, which we are calling them L3 and L4 lumbricals. Remember that the nomenclature starts from where the thumb is and you go this way. So this one is from lateral, okay, where the thumb is, okay, the pollex is, that's the lateral aspect. And as I come here, this is the medial aspect. And so the L3, L4 lumbricals, which are bipinnate, yes, will be getting, okay, their motor supply from, of course, the deep branch of the ulnar nerve. That's one thing I want you to know. Now, importantly, I want to tell you something. As an intrinsic muscle of the hand, this lumbrical or these lumbricals will be relevant in causing something we call, now this is the normal function, upon contractors of normal function. The knuckles, at the level of this knuckle that we find over here, and this is the metacarpophalangeal joint, okay, they will cause what we call flexion. They will cause flexion. And of course, at the various interphalangeal joints, both the proximal and of course the distal interphalangeal joint, they will cause extension. So you can see they are extended. So it tells me something, that if this L3, L4, they are not working, then it will lead to, now look at something, I'm just using this one to explain something. If they are not working, if these lumbricals are not working, regardless of whether it's L1, L2, L3, or L4, then what is going to happen? We said that this normally they are function. So then what is going to happen? Then it's going to be the opposite. So that there will not be any flexion at the metacarpophalangeal joint, at the level of the knuckles. So there will going to be the opposite action, which is of course extension. In fact, actually hyperextension. And then of course, at the level of the both the proximal and distal interphalangeal joint, instead of extension, there will be what we call flexion. And this is something we call claw hand. Claw hand. Now, as far as the ulnar nerve is concerned, we told you that the lumbricals, we are talking about the medial two lumbricals. So it means that there will be something we call ulnar claw hand. So something like that, ulnar claw hand. And I'm going to explain the clinical application over here. Ulnar claw hand. Great. So that is one thing I want you to understand. And then, of course, the deep branch of the ulnar nerve, okay, will terminate its function by supplying one of the thinner muscles which doesn't produce this thinner eminence. Now, it works on the thumb. Now, it's over here, having two hairs, a transverse and oblique head. Okay, I'm talking about something that we call adductor pollicis muscle. Adductor pollicis. So what does it tell you? Now, it means that that muscle is responsible for causing adduction. And what do we mean by adduction? Bringing this thumb, okay, so adductor pollicis, this is the pollex. So causing it to get closer to the other triggers. I'm talking about the index finger over here. This is the adductor pollicis. So it tells me that if there's an injury, okay, for instance, to the deep branch of the ulnar nerve, then you cannot adduct all these things, okay, and all these intrinsic muscles will also be affected, as I'm telling you. Great. Now, having looked at this, and that is why sometimes there may be a question like, what is the graveyard of the ulnar nerve? The graveyard of the ulnar nerve is the level where the deep branch gives the last supply. And my friend, the answer is adductor pollicis muscle. Great. Now, having appreciated all these things, then it makes sense that we look at the clinical application. The first thing that I want you to understand is that whether it's a higher level injury, whether it's at the level of the medial epicondyle, at the level of the arm, or the level of the armpit, whichever way, but oftentimes it will occur at the level of the medial epicondyle. There could be an injury over the higher level injury. Now, what happens is that whether it is a higher level injury or a lower level injury, okay, at the level of the Guyon's canal, whatever, there will be something that we call ulnar claw hand. That will be something which will be evident, ulnar claw hand. Now, the question is why? The reason is that these intrinsic muscles, and important, which one am I talking about? I'm talking about, of course, the medial two lumbricals, not getting innervation. And for this reason, the claw hand that I explained to you. Okay, claw hand. Okay, now, there's something which clinically, yes, it baffles us, but we've got the explanation anyway. And that is something we call ulnar paradox. Ulnar paradox. Now, from our previous explanations to these, injuries, okay, to these long deaths of the upper limb, we've come to appreciate that whenever usually there's a high level injury, then most of the things down there will not be getting, the supply. And for this reason, the severity of the injury will go up compared to if it's a lower level injury, because most of the things would have been supplied. Now, in the case of this ulnar paradox that we are talking about, if rather there's a high level injury, okay, what we see is that the severity of the injury, okay, is minimal compared to if there's a lower level injury. That is the ulnar paradox. So lower level injury produces more, results in severity, higher severity of what we call the injury. So higher level injury rather is milder, but lower level injury is more severe. Now the question is why? The reason is only simple. The muscle, okay, the medial 1/2 muscle, okay, one of the deep muscles of the forearm, anterior compartment of the forearm, okay, flexor digitorum profundus. That is the answer to the question. Now, if it is a higher level injury, then it means that flexor digitorum profundus wouldn't get that supply, and therefore I told you that that kind of flexion, okay, at what we call a distal interphalangeal joint for these two digates. So in situations where, of course, this one is intact, okay, that is in case of lower level injury, it means that flexor digitorum profundus, the medial half, would have been supplied, and therefore there will be more flexion at the distal interphalangeal joint of this pinky, okay, little finger, and of course the ring finger, and therefore you may see that yes, it's like the clawing of the hand, okay, is more pronounced, okay, if it is a lower level injury, because the flexor medial 1/2 of the flexor digitorum profundus will not be supplied. Okay, so that is something that I want you to understand. Now, oftentimes, yes, if also medial nerve is also injured, then of course there will be complete claw hand. Now, in situations, for instance, if there's complete claw hand, there's something that clinically, okay, that we can use to help support this one, okay, is something we call knuckle bender splint. Knuckle bender splint. Now, this splint, what is it going to do? I told you that these knuckles, okay, normally if the lumbricals are working, then it's supposed to cause this flexion, okay, at the level of the metacarpophalangeal joint, and then of course extension at both proximal and distal interphalangeal joint. Now this is going to be opposite in the sense that rather you are having the clawing of the hand. So what do you see at the level of the knuckles, the metacarpophalangeal joint? What do you see? Rather there's hyperextension or there's extension. And so what do we do? So rather we need something which will bend, which will cause flexion. And that is why the splint that clinically you'll be employing is something we call knuckle bender splint. Knuckle bender splint. Now the next thing, having looked at these things, now there's one more thing which we can appreciate, okay, to test whether the deep branch of this ulnar nerve is intact or not, is for instance by testing the adductor pollicis. Remember that I told you that the graveyard of the deep branch of the ulnar nerve, yes, is the adductor pollicis muscle. It's supposed to apply it, and so you are supposed to be able to do this thing that I'm doing, okay, to cause adduction of the thumb to, of course, this index finger. And so one test that we do is something we call Froment's test. Froment's test. Now, inability to do the Froment's test, it means that you are positive for it. Yes, it means there's a positive Froment test. But if we're able to do it, then rather there's a negative Froment test. So it means that as far as positivity and negativity of the test is concerned, it's based on your ability to do the test or not. Okay, so your ability to rather perform the test without any, uneventfully, then it tells me that rather you are negative. By inability to do the test as required, it means you are positive. That's one thing I want you to understand. And so to do that Froment's test, this is what you do. For instance, we can put a paper in between, of course, this thumb and of course this index finger, so this way. And then the clinician will try to pull it, but it asks you to, of course, give some kind of resistance as he pulls it from, in between, of course, your thumb and, of course, your index finger. So, for instance, the clinician is trying to pull it, and you are resisting it. Okay, now you can see that my adductor pollicis is working so well, and so I'm able to resist it. So it means that I am negative, okay, for that, Froment test. It means that the deep branch of the ulnar nerve is intact as far as supplying, the adductor pollicis is concerned. It means that it hasn't been injured. It's working intact as far as, the adductor pollicis is concerned. But failure, okay, to do it this way, okay, but rather, because I'm not able to adduct, rather I grip this paper using, by flexing my thumb. So now you can see that my thumb is flexed. Okay, so my thumb is flexed. Now last week we said that the deep branch, of this median nerve will rather, okay, which we call it the anterior interosseous nerve, will be giving supply to, of course, flexor pollicis longus. You remember flexor pollicis longus. And so flexor pollicis longus, okay, for me to flex my thumb is by the concavity of the flexor pollicis, longus, which is coming, okay, working because it is getting innervation from, of course, the anterior interosseous nerve. Okay, so if I'm rather able to do this, to grip it, then it means that I am positive, okay, as far as the Froment's test is concerned. It means that my median nerve, the deep branch of the median nerve is intact, but rather, right, the deep branch which is supposed to supply the adductor pollicis is not intact. Okay, so that's one of the tests that we'll be doing. Now, another test that we can also do to check the integrity, this time around, of the interosseous. Mainly, I'm talking about the palmar interosseous. Yes, palmar interosseous muscles. That's what I'm talking about. So, for instance, that one, I told that palmar interosseous, the mnemonic is PAD, adduction. Okay, cause adduction. Bring the other digit closer to the middle finger. So this way. So that's adduction. So if I want to test, okay, for the integrity of the deep branch of the ulnar nerve as far as supplying this, interosseous, and mainly I'm talking about the palmar interosseous, is that I'll put a paper, okay, in between these fingers like this. So for instance, between, of course, the middle finger and of course the ring finger, and I'll ask the patient to hold onto it, adduct the digit. I'm trying to pull it, but adduct, okay, so that it gives some kind of resistance to the paper that I'm trying to pull in between the fingers. Okay, so it means that I am negative for that test that we call book test or paper test, actually. Okay, so that is something that we see. But in situations, if the person cannot adduct, then of course, quickly you can move. Then it means that the integrity of what we call the deep branch of the ulnar nerve as far as supplying, the interosseous, yes, there's a problem, especially palmar interosseous, there's a problem. Okay, there's weakness in these muscles. Okay, so these are the things which I want you to understand. Ladies and gentlemen, I'm very grateful for your time. Yes, this evening. Have a good night, all of you, and may the good Lord richly bless you. Amen.